tell them you're live. So I'm sharing the link with Prof.
Oh, okay. So we are live. So I think if you start sharing the link with our contact, that'll be amazing.
I'm watching still not sure.
Prof. Larry, should I remove one of the devices? Okay. Hallelujah. Glory to God. Good evening, good afternoon to our lovely viewers wherever you are. It's an honor and a privilege to be with you once again on tonight's episode of Time with the Doctors. And tonight we are looking at a very interesting topic, fibroid. And I have here with me my co-host, Professor Lai, and Dr. Wanzi Amajo from the United States. Did I get the name right? Good. She's currently working as a clinical assistant professor at the University of Texas, Houston, in the Department of Obs and Gynae, and she's passionate about mentoring young women and helping the under-deserved. I'll be sending my girls over for mentoring. We also have Dr. Michael Intumi from Ghana. He works as a lecturer in the University of Ghana, and he's also an Obs and Gynae, right, at Kolebu Teaching Hospital. And we are waiting for one other panel who is still not here, but I'm sure he'll be joining us shortly. Prof, what do you think? Do you think we should hold on a few seconds for him, or what do you think?
I think we can go ahead, and then he will join us. He's trying to log in, and he's having some issues.
Yeah. Right. Can I kindly ask everyone to please share this lovely broadcast, because it's going to be very promising. Yesterday when we had a chat, these doctors are really ready, and this is right up their street. This is their specialty. This is their bread and butter. This is what they do every day. So please, let's share this information. You never know who you'll be saving. You never know who needs to hear this at this point in time. So if we are ready, then I'm ready. So we are looking at the topic, uterine fibroid. And I had a little read about it, and I saw so many interesting things. So, Dr. Amajo, what are fibroids, or what are uterine fibroids to start with?
Thank you. So uterine fibroids, if you think about a pimple, for instance, on your face, it's basically a growth in the womb. So it's just something that grows out. It's a mass that grows in the womb. And that's really what it is. It's not cancerous. It's what we call benign. So we know a lot of people have fibroids, and that's really what the definition of uterine fibroids are, just a benign growth that happens in the uterus.
So to just continue with that, so how common are fibroids? Is it only present in some societies? Is it something that you see only in blacks, or it's something that is everywhere in every part of the world? So can you kind of talk about how common it is?
So fibroids are very common. So in the US, there are studies that show that 70% of white women will have, up to 70% of white women can have fibroids, and then up to 80% of Black women. Other populations, we don't have real numbers, but we do know that fibroids in women that are of reproductive age, who are childbearing, able to bear children, usually 25% of women will have fibroids. So whether Black, white, Hispanic, women can have fibroids. So that's very common.
So so in terms of how common it is, so it's not really different in different parts of the world, like?
No, it's not really different in different parts of the world. So different parts of the world, if you go to a predominantly Black part of the world, then you may see more fibroids because there are more Black people in that part of the world. So it just depends. But commonly, any population can have fibroids. We see it in Caucasians, we see it in Blacks.
Okay. I think we will continue along those lines. Maybe you can answer the next couple of questions before or maybe we'll ask Dr. Ntumi to answer the next question for us. I mean, whether there are different types of fibroids or not.
So Dr. Ntumi, are there different types of fibroids then?
Yes. So yes, different types of fibroids are classified basically based on the location of the fibroids. Like my earlier colleague said, fibroids are benign tumors of the uterine smooth muscles, but they may be located differently in parts of the uterus, and that will cause a difference in the presentation. So they may be located inside the cavity of the womb, and we call submucous fibroids. They may be mainly in the wall of the uterus, and we call that intramural. And sometimes they may be on the surface of the uterus or the womb, and we call that the subserosal uterine fibroids. So that's how we classify them into the different groups.
Dr. Majo, so I'm coming to you now, is that right? Oh, right. Dr. Prof. Tuli has just joined us.
Okay.
Finally.
Yes.
We're saving the best for last.
Yes. So, so Prof. Tuli, we kind of went on the first 3 questions, and so we're coming to you. So, why do fibroids form? Is there a specific cause for fibroids?
Thank you very much, and good afternoon, good evening, good night to everybody listening.
We don't know for sure why fibroids form. What we do know, though, is that fibroids form when one cell in the muscle of the uterus begins to grow out of control. So unlike the two types of abnormal growths, there's cancer and there's what is called benign. So fibroids will belong to this group of non-cancer excessive growth, usually starting from one cell within the muscle of the uterus.
So just to follow up on that, are there any specific risk factors for developing fibroids? And also, does fibroids run in families? And then whilst you're at it, can contraceptive pills contribute to the formation of fibroids?
So that's a very good question. So we know that in many women, this abnormal growth may start and begin the process of a fibroid. But in some women, it grows and eventually becomes a large mass, which may have some of the symptoms and signs that I'm sure have already been described. There are some risk factors for fibroids. So some women are more likely to develop fibroids than others. So we know that Black women are more likely to develop fibroids. In fact, in the US, about 1 in 2 Black women will have fibroids, while about 1 in 4 white women will have fibroids in their lifetime. So we know race, ethnicity plays a role. We also know that there are other factors such as nulliparity. So in general, women who have never been pregnant, never had a baby, are more likely to have fibroids. Whether this may be because some women with fibroids do not get pregnant, or it is that fibroids are more common when you haven't been pregnant, it's unclear. Other factors also contribute. So for example, body weight may play a role. So those who may be slightly on the heavier side are more likely to develop fibroids. We think this may be because fibroids respond to hormones, and these hormones are able to concentrate in fat tissue. And so for women who may be on the heavier side, that may be a risk factor that increases the chance of developing fibroids. You mentioned contraceptives. So we know contraceptives contain 2 hormones generally. We have the estrogen and progesterone. We know that estrogen plays a role in the growth and development of fibroids, but it's not a one-to-one equation. Some women will take contraceptive pills and never develop fibroids, while in some cases, their fibroids may grow in response to that. In terms of whether fibroids run in the family or not, fibroids will be what we call, multifactorial causes, meaning there may be some role of, family history and heredity, but there are also lots of non-hereditary factors. So there are some patients who will tell you from their grandmother to their mother to themselves and their siblings have fibroids. But it is not a one-to-one transmission, meaning just because your mother had fibroids does not mean that you are going to develop fibroids too.
Right, so lovely viewers, Professor Methodius Tooley just joined us, and he is a professor of Obs and Gynae at the Brown University in Rhode Island. He's also the chair of the department and internationally renowned researcher in Obs and Gynae. So once again, this is right up his street. This is his bread and butter. This is what he does every day. And his area of subspecialty is maternal fetal medicine, and specifically high risk obstetrics. So I think if you are expecting quadruplets or twins or triplets, please see Professor Tooley. Right, thank you very much for joining us, Professor Tooley. Dr. Ntumi, my question comes to you now. So, can fibroids be cancerous then? Because you did say they are benign, but you are just wondering, can they be cancerous?
No, like we heard my earlier said, fibroids are typically benign tumors. So the probability that they become cancerous is very, very rare. I mean, it's said that if you take about 1,000 women with fibroids, less than one would probably develop a malignancy or be converted to a malignancy, what we call a sarcoma. So typically we consider fibroids as cancerous, but there's a small risk, especially in postmenopausal women, that there may be a possibility of developing coma. So that when you have a postmenopausal woman presenting with abdominal pain and enlargement of the womb, we shouldn't just assume that it's small or just a simple fibroids. We need to look at it more closely.
Thank you, Dr. Ntimi. We'll continue with you. So, we've talked about, fibroids and how common they are and the risk factors. So, how does a woman know that they have fibroids? Like, what are the symptoms of fibroids? You know, what are the classical symptoms? And then, as a side, I will ask this: is it true that patients with fibroids can present with psychological or emotional symptoms? And then, if you can also address the fact that sometimes a woman may show up, with rapid growth of the abdomen, which they may think they are pregnant, and then eventually to find out that this is fibroids, and why does that happen? So it's kind of a multi-loaded question, but if you can just tell us how patients present.
Well, all right, thank you very much. So to begin with, I'll say this like what I always tell my students, that the commonest symptom of uterine fibroids is that they are asymptomatic. So women with fibroids will not have any symptom at all. So we tend to discover them accidentally when they come for routine examination or they go to the hospital and decide to scan them. Then we discover they have fibroids. So most people with fibroids will not have any symptoms at all. But for those who have symptoms, they have symptoms that they may have either individually or all together. So they may have, the commonest of these will be abnormal uterine bleeding. Typically, the women may notice that they have heavy and or prolonged menstrual flow. And it goes on for so many months and sometimes they become so anemic. In cases, they may have such abnormal patterns that the women cannot even tell which of these bleeding is their menstrual cycle or the menstrual period. Then they may also bulk effect. The uterus gets so big that it begins to compress and on the structures in the pelvis. So typically they may compress on the bladder sac that stores urine in front, and they may begin to pass urine in frequent intervals. We call them urinary frequency. They may also in sometimes have a kinking of the tube that carries urine out. So they may have acute obstruction where they have difficulty in emptying the bladder. They may have the strong, but they will not be able to empty the bladder. A few times they may have difficulty and have hesitancy, they hesitate, take a long time before before the urine comes out. Sometimes they may have constipation. They may take all the fiber diet and yet they have constipation because of the compression of the uterus on the large bowel. Then they may also have some issues, problems with reproductive function. That is, some women may have infertility because of the fibroids, and a few of them may also have increased miscarriages or preterm labor or preterm delivery purely because of the. So when these women come with the symptoms, typically we examine them and we ask them to do scans, and the scans are able to confirm the fibroids. Now you also whether these fibroids or symptoms may have psychological effects on this patient. Yes. So women who have symptoms from fibroids, especially abnormal uterine bleeding, tend to act like women with chronic diseases. So they get so worried, some of them get depressed because of the continuous bleeding. So they are worried, they are unable to go to work, they may be able to perform their functions. So they get so stressed out. There is a psychological aspect of it. And in that part of the world, especially in the West Africa sub-region, most of our women equate presence of fibroids to infertility. So once they discover that they have fibroids, automatically they think that they will not be able to get pregnant, they're going to have infertility. Significant psychological impact on these patients. Now, yes, we've had quite a number of patients that will come with very fibroid uterus, so huge that everybody else thinks that they are pregnant. And indeed, a lot of these women go to the churches and other medical practitioners who told them that they have kids, they are pregnant, and they've been waiting for months on end to deliver. Till they come to the hospital when we discover the pregnancy, this is just a huge uterine fibroids, and then we have to take them through counseling and then offer the help that is needed.
Oh, Maud, you're muted.
So happens. Dr. Margot, so what specific tests does one have to undergo to be diagnosed with fibroids?
In terms of testing, you're initially going to present to the doctor, and the doctor will do your pelvic exam. So a routine pelvic exam, checking your abdomen and your pelvis, will sometimes reveal that it is a large mass, which is suspected to be a fibroid. And afterwards, the doctor can refer you for ultrasound, just to make sure that it is indeed a benign fibroid. If, for instance, you're close to menopause or it's a very large mass, they may recommend an MRI as well. So those are usually the tests that are performed.
So to follow up on that, Dr. Majo, so the question is, do fibroids require treatment? And we can see a question from Jacqueline Baxter Holland saying that she's heard that fibroids typically shrink once a woman is in menopause and it's therefore unnecessary to have them removed. Is this truth or myth? So as you talk about it, can you answer the question?
Sure. Sure. So fibroids, not all fibroids require treatment. It depends on the size of the fibroids and the symptoms. So if the fibroid is asymptomatic, as Dr. Ntumi referred to, which means the patient does not even know she has fibroids, it was just an incidental finding on a scan, then you do not require treatment. However, if the fibroid is causing symptoms like heavy periods, painful periods, painful sexual intercourse, abnormal bleeding, and even the frequent urination, and obviously sometimes the bulkiness that makes the woman to appear pregnant, those fibroids can be treated. In addition, there are some medications that can put you in menopause that can also cause the fibroids to shrink. And when the patient is in menopause, most fibroids will shrink as they are no longer getting estrogen or the hormones that can cause the fibroids to go away. So yes, fibroids can indeed shrink after menopause. So you don't routinely see people going for treatment for fibroids after menopause.
So does that mean, at least from her question, her question was that since the fibroids will shrink with menopause, then does that mean that we don't need to treat the fibroids? So when they get to menopause, it will shrink anyway?
Yes. So most people do not do any interventions after the patient is menopausal, except it's really big and causing other pressure symptoms or constipation, causing the kinking of the tube that connects the kidney to the bladder, causing frequent urination. But most times, if the fibroids are known to shrink, then people don't treat after menopause.
And thanks, Dr. Amadio, for that. And Prof. Tuli, so what are the treatment options available, and are they all surgical?
Thank you for that question. So there are different treatment options for fibroids. And if I could step back a little bit and talk about the different types of fibroids that we may have. So patients may have fibroids that have symptoms or fibroids that come with no symptoms. Fibroids may be a single fibroid, they could be multiple. They could be small, they could be large. But most commonly, we classify fibroids based on the location of the uterus where the fibroid is. The uterus has 3 layers. The outer layer, the outer covering of the uterus is called the serosa. So when there's a fibroid there, it's called the subserous. or subserosal fibroid, which is on the outside. If the fibroid is within the muscle of the uterus, it's called intramural type fibroid. And if it is closer to the lining of the inner lining of the uterus, then it's called submucous. The vast majority of symptomatic fibroids tend to result from the submucous fibroids, so those that are within the lining of the uterus, because they are the ones commonly associated with abnormal uterine bleeding and menstrual abnormality. Those that are associated with the pressure effect tend to be those that are going out, the subserosal, or they may even be hanging on the outside of the uterus, or large ones that are within the muscle of the uterus. So as my colleagues rightly said, most patients who have fibroids do not need treatment if they are not causing any symptoms. If they are causing symptoms and are problematic, the treatment depends on the symptoms they are causing and the size as well as the location of those fibroids. So the first is medical treatment. If the main issue is with abnormal bleeding, there are hormones like Depo-Provera or other hormones that put you into menopause and reduce the size of the fibroid and also tend to reduce the symptoms of abnormal bleeding. It's important though to note that those hormones that put you into menopause and cause the uterus to shrink, the fibroids to shrink, when you stop taking those medicines, the fibroids tend to grow again. So we normally would use those medications sometimes before surgery in order to shrink those fibroids so that certain types of surgery may be possible, which will not be if they were too large. But there's a downside to doing that too before surgery, because if we shrink the size of the fibroids, very small ones, you may not see them at the time of surgery, which means you remove what you see and those smaller ones will grow again when you are no longer taking the hormones. There are other methods which I will call minimally invasive. So you undergo a procedure which helps to treat the fibroids, but it's not major surgery. One of those is called uterine artery embolization, where at radiology, the radiologist puts in a tube to the blood vessels that feed the fibroid and put in some gel or other material to obstruct the blood flow to the fibroids. And the fibroids tend to shrink after that, and the symptoms tend to reduce, if not disappear. One has to be careful though when using this method, because we tend not to recommend it if a woman plans to get pregnant after that, because we know there's an increased risk of pregnancy complications if a patient has this procedure of blocking the blood supply to the fibroids and subsequently gets pregnant. There's now new technology which is being developed and being used in some centers where high ultrasound waves are directed at the fibroid and applied to the fibroid, and then it tends to shrink eventually. This is still experimental and not widely used. The last resort is surgery, and there are basically two types of surgical procedures. You can remove the fibroid or you can remove the whole uterus. Which of these you choose depends on where the fibroids are, how old the woman may be, and what their intentions are in terms of subsequent fertility. So in a woman who has never been pregnant and who is undergoing fibroids because they are worrisome or because we think this may be related to their infertility or pregnancy complications, then the goal is to remove just the fibroid. We always, warn women though that because women can bleed unexpectedly during the process of removing the fibroid, what is called myomectomy, we really counsel women carefully before we do this, because sometimes we go in to do surgery just to remove the fibroid, but the patient is bleeding so heavily that we are unable to save the uterus. And in terms of surgical techniques, there are different ways to do that depending on the location of the fibroid. If it's near the inner lining, you may go through the cervix and remove it that way. You can use a laparoscopy, which is putting a camera through the belly and removing the fibroid. There are robots now being used for surgery. And then the last resort is where we open up the abdomen and either remove the fibroid or do a hysterectomy, as may be indicated.
Thank you for that answer. So I think that answers my next question. That if a woman is undergoing surgery for fibroids, it does not automatically mean that they are going to have their uterus removed or their womb removed.
That is absolutely correct. And before surgery, usually we will sit down with the patient and discuss, the reason why surgery may be, or a procedure may be indicated, and plan the surgery. And so, in many cases, it is just removing the fibroid, but we always counsel women as well that there's always the possibility of unexpected bleeding, which would necessitate bigger surgery than we intended. And that is one more reason why we should not be doing surgery on fibroids unless the patient has significant symptoms or unless we've linked it clearly to pregnancy, infertility, or pregnancy complications. And the reason is we may go in for what may be a planned simple procedure of removing the fibroid, and it could end up being a hysterectomy. So we only want to do surgery when it's clearly necessary.
Thank you, Prof. Tuli. Dr. Tumi, my next question comes to you. But I know Prof. Tuli has actually touched on that. He's actually told us there are different surgical approaches. But I want you to just go over it a little bit, especially for our viewers who are back home in Africa. Are all these surgical approaches that Prof. Tuli described, are they all available to them? What we have available and ready available in Ghana and in Kolebu for that matter?
All right, thank you very much. So Tuli said, yes, there are surgical interventions, and we tend to offer them based on the symptoms complex and where they want to have achieve further pregnancy or not. So for us in Ghana here, on most of the West African South, we have the surgical procedures that can take care of hysteroscopic procedures. For instance, if the woman is bleeding or the problem is because of heavy menstrual bleed, abnormal bleeding, and we've assessed them, we found out that the problem is mainly from a submucous. Then we have the facilities to offer hysteroscopic resection, where we go to the vagina and the cervix and just resect that, so that this woman can have relief from heavy menstrual bleeding and also maintain her future reproductive function. So hysteroscopic resection or hysterectomy is available in Ghana and most of the West African sub-region. We also have the laparoscopic myomectomy that he mentioned. Yes, few centers now doing that. The challenge, however, is that we observe that most of our women tend to have multiple fibroid nodules and very huge by the time they are presenting. So even where the technique and the expertise is available, for most of our patients, laparoscopic myomectomy is adjustable. We have to resort to open myomectomy. I don't know, however, if there's anybody in the sub-region who do robotic laparoscopic surgery. So for that, we have. But ordinary laparoscopic surgeries, yes, a few centers are offering in Ghana here and in the West African sub-region. But by and large, most of our patients, about 80% of our surgeries, we have to resort to the open laparotomy. And abdominal myomectomy is a major surgical procedure here. I mean, when we take all the cases that we do, for instance, a major gynecological surgery, we found that about 6 out of every 10 organic surgery have to do with uterine fibroids, and about half of that will be from myomectomies. So myomectomy is available, and hospitals in Ghana with specialists are able to carry out a myomectomy. Now, in a few cases where the fibroid is so big, or the woman has completed a family, or like Prof. Tuli said, technically it's just not possible, or she's bleeding, then we have to resort to hysterectomy. Usually we do that by abdominal hysterectomy. There are a few times when we are able to do vaginal hysterectomies for these cases. But like I said, most of them present huge, bulky uterus. So that option is not possible. So we have to almost always resort to abdominal abdominal hysterectomies. So those are options that are available to us in the sub-region. I mean, just to mention again, also that some of the less invasive procedures that you mentioned, like uterine artery embolization, again, yes, this is available in the sub-region and is being done. The only problem is that we do not recommend that for women who want to maintain their reproductive functions, so that if you are planning to get pregnant, we will not want you to probably go for that option. The other thing is that that option is quite expensive for most of our women, so that even though it's available, the patronage is not that high. But that is what we have in the sub-region.
Okay, thank you.
Continue.
Okay.
Can I just ask a quick follow-up question? Because you did say that most of your cases are open laparotomy. Is there a reason for that?
Yes. So first of all, a few years ago, we did not have the expertise for this minimally operative surgical procedures. It is now coming in. So for most doctors, the expertise or the experience is with open surgical procedures. But the second reason also is that we have patients that present very bulky fibroids. I'll give you an example. In my hospital, the smallest size of the uterus that you're going to operate on during surgery will be about 20, 24-week size. And that is for us the smallest that we can get. Most of them come with 26, 28-week size uterus. And technically, those patients may not benefit from this minimally invasive procedures. And then is size the issue, but the number of fibroids. It appears that the pathology here, the women have a lot of fibroid nodules, sometimes 30 pieces, 20 pieces, 40 pieces, 50 pieces. So when you have that kind of pathology, the open surgery is what we tend to offer for most of these patients.
So maybe I'll go to Dr. Majo and Prof. Tuli. What is your experience in the U.S.? Do you see something similar to what Dr. Ntumi is saying in terms of the size and the numbers of fibroids that they encounter in Ghana? Maybe we'll go to Dr. Majo first and then.
Yeah, similar to what Dr. Ntumi said, most times when patients present for surgical removal of fibroids, they have big uteruses, okay? Either whether they're presenting from myomectomies or hysterectomies. At that point, they have enlarged uteruses. And most of the times we can only do open cases, especially predominantly in the Black population. So that is the same experience in our patient population, because a lot of times these patients are not very comfortable, or these women aren't very comfortable doing any surgery until it's become very necessary.
So I will say that. Go ahead.
I'm just wondering, does it mean that time is of the essence then, or because the longer you live it, does it mean it grows even bigger if you wait for so long? Any of you could answer that, please.
Okay, I will take that. So
Yes,
I will say let me describe the experience in the US first. So I will say it's mixed. So there are many women who maybe because they have very regular medical care, we may find a fibroid, choose to observe it, and they have an ultrasound maybe every year or every 6 months, and then it becomes bothersome and they choose to have surgery. And in that case, it's still possible to do myomectomy for those patients. But we also see some of the patients later on in the course of the pathology. And I think both Dr. Ntumi is right that it appears that our Black women tend to have those multiple fibroids, and they also tend to be diagnosed later on in the process. So if we find them later in the process, we have limited choices as well. But otherwise, then either laparoscopic or open myomectomy, or even robotic myomectomy, which allows sometimes some more complex surgeries to be done than laparoscopic may be indicated. And you asked the question, so it's time of the essence. So I would say it's not straightforward. As we mentioned, the majority of women who do not have symptoms do not need treatment. and many will undergo menopause, which will result in shrinkage of the fibroids. So I think if a fibroid is diagnosed, a prudent way to do it is not to have it diagnosed and never see a doctor for 5 years or 10 years, at which time you may then have a lot of symptoms and it cannot be managed by myectomy alone. But I would say the fear of growth alone should not lead one to rush to surgery because it has all of those complications we discussed previously.
Okay, so let me go back to Dr. Ntumi. So let's say a woman is going to have surgery for fibroids, right? And they want to know how long does that surgery last? Will they need to be put to sleep? And or is it something that they are partially awake for? Can you address that?
Okay. So thank you. So basically, the duration of the surgery depends, first of all, on the approach that we use and the pathology that we find. I mean, if we are going to do, for instance, hysteroscopic myomectomies, we have a single intracavitary fibroid that we are going to remove. It's a simple procedure and may take a few minutes, and recovery is, a few days. That woman is ready to go back to work, so it doesn't take that long. But if you compare and contrast that with a 28 size uterus that we do myomectomy for, that takes a much longer time. So the duration of the surgery depends on the type of approach you're using and also depends on the pathology you find. So it's difficult to give a straightforward answer. Again, about the form of anesthesia, for most of the cases that we do, which is the open laparotomy that we have here, most of our patients, we give them regional anesthesia so they don't have to sleep. It is only when the uterus is so huge, occupy the whole of the abdomen, and we think that in manipulating it may cause so much pain. That is when we go for general anesthesia where they have to sleep. But I can say that about 80% of our patients would have a regional anesthesia. So a procedure is going on and they are awake, we chat with them, they can even sing if they want to. But if it's a laparoscopic procedure, for instance, then that has to be a general anesthesia because they necessarily must sleep for us to be able to give the laparoscopy and proceed with the procedure. So that's how it was based on the approach you are using and the pathology you are dealing with.
So as a follow-up, when you say regional anesthesia, can you, because I don't think our listeners will understand what you mean. You mean like epidural or spinal?
Okay. So yes. It could be epidural, sometimes it could be both. So you give an injection at the back into the spinal space, which is called the spinal, and sometimes they put a catheter in the epidural space, just close to the spine, and then they're able to administer medication from time to time. That's the epidural analgesia. Sometimes they do both, and they use epidural for post-operative pain management.
Thank you, Dr. Ntumi. I'm still on you, Dr. Ntumi. So you've already answered that it depends on which type you are going for and how long the process would last for. But my question is, let's say you've got a young family, you've got kids at home, what can you go back to? What can you do when you go back after the surgery? Are there things that you cannot do? Or once you get back, you can get back to life as usual?
Yeah, this is a very interesting question. I know that in this part of the world, some people say when they have surgery, they think that their life is changed forever. Because I've had surgery before, there are things I cannot do. There are some food I cannot eat. But it's not like that anymore. Once you're fully recovered, there's nothing that you couldn't do. You're able to go back to your normal life. If you have a hysteroscopic surgery, after 3 or 4 days, you go back to work. You go back to work, life is back to normal. When we have the open surgeries, usually we give them about 3 to 4 weeks to recover. And by 4 weeks, most people are going back to work and they live their life normally. There's nothing like, I don't have to climb this stairs, I don't have to lift this weight. No. So once they're fully healed, they're able to go back to their normal life. Their life is not affected in any way by this surgery.
Okay, thank you. So Dr. Majo, I'm coming to you next, and then we will probably try to answer. There was a question that we'll try to answer in conjunction. So the question is, after someone has had surgery or a procedure for fibroids, can the fibroids come back, right? And then the question that a viewer was asking was, are there foods that can prevent fibroids? So if you can answer that. I think there's another person asking the same question now.
Let me answer the question.
Okay.
And I don't know if my colleagues have anything else they can add, but as far as foods that prevent fibroid, we don't know of any particular foods that prevent fibroids. But we know that obviously living a healthy lifestyle, limiting your fat intake, exercising, that can help basically prevent any adverse health consequences. But in terms of particular foods that prevent fibroids, I'm not aware of any. So I will talk about the question which you asked, which is, could fibroids come back after treatment? The truth is, like my colleagues alluded to, most times people that have fibroids, they have multiple fibroids. Majority of patients that come in for surgery have more than 2, 3 fibroids. Some are large, some are small, and sizes in between. So when you're having the surgery, most of the fibroid is taken out and some may be left depending on how small they are. And so these fibroids that are left can actually grow after surgery. It's a slow growing process, but yes, about 10 to 25% of people who have surgery the first time to take out their fibroids will require another surgery if they want to take out fibroids again. So fibroids do grow back, unfortunately, after surgery. And then if you get to menopause, then they stop growing, which we talked about earlier.
So is it safe to say that the fibroids that grow back, as you said, are not it's not like the one that you removed that grew back, but there may have been other smaller ones that
Yes, there may have been smaller ones that were left. And then sometimes just new fibroids grow. So those are the two reasons that you can have, you could have done fibroid surgery and then later on you get a scan and they still say you have fibroids and then you're wondering, why do I still have fibroids when I took them out before? And that's usually the case because either they were, some little fibroids were left behind that have now grown or new fibroids have started growing.
Thanks, Dr. Maggio. So just to clarify, it's not a strategy that doctors use just so that you can keep going back and then they keep charging you more money.
No, not at all. It's not a strategy to cause you to pay more money for more operations because anytime you operate on a patient, there are risks. Anytime you do fibroid surgery, there's risk that you may encounter really heavy bleeding at the time of surgery that not only do you have to take the fibroid, you have to take the woman's womb out. So before we do surgery, we make sure the patients are counseled extensively before undergoing such surgery. So we wouldn't want to do surgery repeatedly except is absolutely necessary. So if you have fibroids that have regrown, it is not because the doctor is lying or is telling you just to come back from surgeries because it's probably regrown.
Thank you very much. So viewers, be rest assured, when they say the fibroid has grown back, it's not because your doctor was incompetent or he's trying to get more money out of you, but it's just because they do grow. And like Dr. Proplai asked, it's not what was taken out that has grown back, it's the little ones that were left behind that has grown. So Dr. Maggio, what are the consequences if you refuse to treat your fibroid? What are the complications?
Oh, thank you for that question. That's a good question. When you have fibroids, they can either cause symptoms or they do not cause symptoms. So if you start off and the fibroids are not causing any symptoms and they're small, then typically there's no consequence if you leave them alone. Okay. And especially depending on the age of the woman. If the woman is approaching menopause and they're small fibroids and they're not causing any problems, then typically there's not really any consequence to not treating those fibroids. Now, if the woman is starting off at reproductive age and she wants to have children and she has large fibroids, and then you may be advised at that time to take out fibroids, not necessarily because they're causing infertility, but because they might compete with the growth of the baby for blood supply. And so if they're really large, before you have children, we will typically ask you or recommend that you take out the fibroid. If there's causing symptoms, you have multiple fibroids that are causing symptoms and causing you to lose a lot of blood because of your heavy cycles, and you're needing even blood transfusions from anemia, then we would recommend that you take out the fibroid. So that is a consequence of letting the fibroid keep growing, losing lots of blood. Sometimes women who come in and need blood transfusion because their fibroids have grown, or they're bleeding abnormally, or they're bleeding heavily. Another consequence of not treating fibroids is that your womb will continue to enlarge, and you can start to appear pregnant. So when Dr. Ntumi talked about 24-week size uterus, it's equivalent to looking 6 months pregnant. So imagine carrying around a 6-month look as though you're 6 months pregnant or 8 months pregnant, and you're not necessarily pregnant. And that's upsetting to most women who appear to be pregnant and they're not carrying a baby. So that's one of the consequences. So you can have the bleeding, like I said, the appearance of being pregnant, the constant urination, if the uterus is big and bulky and pressing on your bladder, you can urinate frequently. You can have fibroids that are causing pain when you have sexual intercourse, and they're getting larger, and it's causing more pain and difficulty with sexual intercourse. Those are some of the things that can happen as a consequence. And then the larger the uterus is, the more complicated the surgery can become. If you wait till the uterus has a lot of fibroids and got really big, then sometimes it's harder for the doctors to perform a myomectomy, which is taking the actual fibroids out. At that time, the doctors may resort to taking out the entire uterus, because it's more difficult, more complicated, and more chances of significant blood loss, which is hemorrhage at the time of the surgery. So those are some of the consequences of letting your fibroids continue to grow.
Okay, so now we'll shift gears. I'll come to Prof. Tuli. And there's a question here as well. So I think I will rope that in for you to answer. The question from Pastor Dickinsando is, what's the difference between fibroids and ovarian dermoids? But my question to you is, can fibroids prevent conception or pregnancy? I mean, in other words, can fibroids cause infertility?
So let me start off by answering the question, the difference between fibroids and ovarian dermoids. As I mentioned earlier, fibroids are masses that grow out of the muscle of the uterus. So they tend, except in rare cases, to be masses that are in or attached to the uterus. Ovarian dermoids are masses that are on the ovaries. They are attached or inside the ovary. And dermoids in particular are very interesting masses. So these develop from what we call germ cells, meaning cells that can grow into any part of the body. So dermoids tend to contain fluid within them, and they can have all kinds of tissue, including hair, teeth, and even thyroid glands inside the dermoid. So the basic difference is that fibroids are masses of the uterus, dermoids are masses of the ovaries. Fibroids develop from muscle within the uterus, while dermoids develop from germ cells within the ovary, usually fluid containing, and can contain multiple other tissue. So moving to the question about fibroids and infertility and pregnancy, I want to be very careful about this answer because I think it's really important. As we said earlier, up to half of Black women may have fibroids in their lifetime. And since Black women and other women may also have infertility, it is common for a woman to have both infertility and fibroids, and most often the fibroids are not responsible for the infertility. So just because you have infertility or pregnancy loss, and if we find fibroids in the uterus, does not mean it is the fibroids that are causing you to be infertile. For us to say that, a number of conditions usually have to be fulfilled. One, that we do a thorough assessment, including tests, to rule out the other causes of infertility. For example, male infertility is probably as common as female infertility. And so just because your wife has fibroids and you, the couple, is suffering from infertility, doesn't mean it's the wife. It may actually be a male factor infertility, and therefore going after the fibroids may not solve the problem. So a thorough assessment to make sure the infertility is not due to other factors. And then where the fibroids are located may also cue us into the possibility that it may be related to infertility. So if there's a huge fibroid near the tube, which may be obstructing the ability of the eggs to move from the ovaries through the fallopian tube into the uterus, we may think that that may be contributing to infertility. If there's a fibroid which is within the inner cavity of the uterus, or a large fibroid near the lining of the uterus, we may think it's related to infertility because it may act like an IUD, which prevents, a fertilized egg from implanting, or it may promote recurrent, meaning repeated losses. So just to state once again for clarity, in some cases, fibroids may be contributing to infertility. But just because you have fibroids and have infertility does not mean that it is the fibroids that are causing the infertility. If the factors are described and we rule out other causes are satisfied, then we may attribute fibroids as a contributory factor and therefore recommend treatment.
Thank you, Prof. Tuli. Now, viewers, if you want to know more about infertility, that's the topic we are dealing with next week. So join us next week, 8 p.m. British Summer Time, and we'll be talking more about infertility. But thanks so much for that clarification, Prof. Tuli. Now, my question once again to you is, how does fibroids affect pregnancy then?
Okay, so thank you for that question. So commonly, when I see patients, I do an ultrasound. They may have a healthy growing pregnancy and we see a fibroid. If it's small, again, just like infertility, it is common for pregnant women to have fibroids, and the fibroids totally have no impact on the pregnancy. However, we know that taken together, fibroids, patients who have fibroids may have a higher risk of some complications compared to those who do not. Examples of these may be pregnancy loss, especially, as I said, the fibroid is within the lining of the uterus, and the embryo implants, the baby implants around that fibroid. It may be associated with pregnancy loss. On average, there's a higher risk of preterm labor and preterm delivery in patients who have fibroid, especially if they are large compared to those who do not. Pain is an important factor for fibroids. We know that in some women, the fibroids grow larger during pregnancy and may undergo what is called degeneration, meaning they are outgrowing their blood supply and they can become very painful. We tend to treat those medically most of the time, except in very rare cases. We also see that there may be an impact of especially large fibroids on fetal growth. In some cases, the fibroid may be even much larger than the developing baby, and you see the baby squished within the uterine cavity. Fibroids may affect how the baby presents at the time of delivery. Instead of the baby presenting head first, which is the way we want it to be, if the fibroid location may result in the baby presenting with the bridge or transverse. Fibroids may obstruct the pathway to delivery if they are located in the lower part of the uterus or a large fibroid in the cervical region. And in general, because of some of these complications, women with fibroids may be at a higher risk for needing a cesarean delivery than patients who do not have fibroids. A related question is, sometimes patients have fibroids and they have treatment and then they get pregnant. That may also impact pregnancy complications and how we recommend that they deliver. If they have a large fibroid which was removed by myomectomy, and especially during that removal, the surgeon gets into the cavity of the uterus. Those patients, we generally recommend that they have cesarean section for their delivery, because that old scar may not have healed very well, and if you attempt a vaginal delivery, it could open up what we call uterine rupture, which could place both the mother and the baby in danger. Oh, I want to mention this as well. Commonly I see patients who have fibroids and they are going to have a C-section for whatever reason, and they will ask me, "Oh, doctor, can you just remove the fibroids at the same time?" So generally, we discourage removing fibroids at the time of a C-section, and the reason is that during pregnancy, fibroids tend to grow in many patients, and also the blood supply to the fibroid grow larger, and so they are very vascular. And if we attempt to remove the fibroids during a C-section, it may lead to excessive bleeding and maybe even lead to you needing to do a hysterectomy by removing the whole uterus. Besides, in the women where the fibroids grow during pregnancy, they tend to shrink again after pregnancy, and therefore it may not be completely reasonable to go to try to treat those fibroids by removing them when there's a chance that they could shrink after pregnancy. However, if we are doing a cesarean section and a fibroid is in the way, so where we make the incision to deliver the baby, the fibroid pops up during the C-section, we tend to remove it because we have to close the opening of the uterus, and we often cannot do that if the fibroid is in the way. So in some patients, we may remove the fibroid during cesarean section, but we tend to say that is incidental, meaning we happen to be able to remove it, than that we purposely went after it. There are some physicians and some studies that have suggested that it may be possible to remove fibroids in a few selected women, but this is selected. So for example, you go in to do a C-section and there's a fibroid which is hanging outside of the uterus, attached to the uterus by only a small, what we call pedicle. In some of those studies, removing those types of fibroids did not associate with an increased risk of complications. But in general, it should be the exception rather than the rule, that because you have fibroids, when we do a C-section, we are going to be able to remove them safely.
Okay, so it looks like there are a few questions that we want to kind of bring in. Some of them may have been answered already. A question from Colleen Isaac is saying that chances are that the fibroids grow twice the size after the first surgery, and she's saying she's experiencing it. So maybe Dr. Amadio, you can speak to that. And then the same person asked the question about, about whether it's advisable to do laparoscopic surgery on multiple and very large fibroids. I think that has been answered, that, for that reason, most of the time it's done open rather than laparoscopic. So I think that has been answered. And then there was another question that said, is it after fibroid surgery, when is it advisable to get pregnant? So I think maybe Dr. Amadio can answer the first one, and then either Prof. Julie or Dr. Jimmy can answer the second one.
So I think the question was, or her statement was, I've had fibroid surgery and now it's grown back twice the size, right? Okay, yes. I think we talked about that earlier, that once you've had fibroid surgery, that does not mean you will not need another procedure, because whether or not the surgeon knew, they could have been smaller fibroids that were left in the uterus, and those smaller fibroids can get bigger, or there can be a new growth of fibroids. So I'm not sure if it's exactly twice the size, but we know that fibroids do grow back after surgery. So that is a common experience. Most people talk about, especially if they're still of reproductive age and they have not gone through menopause. So let's say you had your surgery when you were much younger, and then 4, 5, 7 years later, you do another scan or you start to have symptoms, it is possible that you will have fibroids again. And I hope I answered the question.
Yes, I believe you have. Dr. Ntumi or Prof. Tuli, can you speak to kind of how long after fibroid surgery should a woman kind of plan to have a pregnancy?
I can take that.
Yeah,
So,
okay.
Dr. Ntumi, go ahead.
No, Prof, you go ahead. Go ahead.
Okay, so as Dr. Ntumi mentioned earlier, in the different types of treatment, it to some extent depends on what type of treatment you have. So if you have a hysteroscopic myomectomy where it's a small fibroid dangling inside the cavity and we go and remove it, it may be a couple of months. Once you heal, you can go ahead and get pregnant. Also, if there's a fibroid which is hanging on the outside of the uterus, what we call a pedunculated fibroid, we go in and remove it. After you heal, you should be able to get pregnant. The big question is, if we do major surgery, the open surgery, where we cut your uterus and remove these large fibroids and then close it up, how long should you wait before you get pregnant? And it sounds like it should be a simple question, but it's not, because there are two competing things. You want to get pregnant soon enough so you don't have big fibroids growing again, and yet you want to wait long enough so your uterus is healed and you reduce the chance of complications, including the uterus rupturing, meaning opening up while you are in labor or something like that. So probably the data that helps us best, the studies that help us best to tell which of these directions to go, maybe the idea of how long after cesarean delivery should a woman get pregnant again, because in terms of the big fibroids, it's very similar. And we know that if women get pregnant, especially less than a year to 18 months after cesarean section, the chance of having a uterine rupture is higher compared to if they wait longer. So I will say it will depend on the extent of the surgery on the uterus, but most of us will say within the 6 months to a year sort of range for you to get pregnant again. In some cases, we may say a little longer if that surgery was very extensive. And as I said, in many cases where it's very minimal, like a hysteroscopy or a hanging fibroid that we remove, then we may say that you could wait just a short period of time and could get pregnant.
So let me ask a follow-up to that. So let's say you're doing you're removing a large fibroid where you have to cut into the uterus and remove it. Do you then combine that with some form of contraception, like an IUD or something like that? Is that a common conversation that you have with a patient when you are doing that type of surgery?
So, in my practice, we tend not to do that. Part of the reason is that, after you do a myomectomy, especially for any uterine surgery that you go into the uterine cavity, you want to promote healing of that uterine lining. And sometimes we may give hormones, estrogen type hormones for the purposes of growing the lining of the uterus. And say intrauterine contraceptive devices, especially the progesterone containing ones, they tend to thin down the lining of the uterus. Another concern, although it may be minimal, is that you just made a scar in the uterus and then you put in a device. Is it more likely that it's going to embed in the scar? I think we tend to do that even after C-section, so I don't think that risk is too high. But in general, we may advise that patients use contraception, but we tend not to, for example, put in an intrauterine contraceptive device at the time of surgery.
Dr. Ntumi, is your practice different in Ghana with respect to this?
No, it's basically the same. We always ask them to, because we do this extensive myomectomies, we always ask them to wait for a minimum of 6 months before they begin to attempt to get pregnant. And so we have to discuss different options of contraception with them. But typically, we do not input in an IUD for the reasons that Prof gave. So sometimes if they use their natural method, natural cycles, others use the combined pill especially. That's the commonest method most of them use. A few of them will use the progesterone-only method, except that we warn them that sometimes a delay of return to menstruation when you use those methods. And so most of them will accept to use barrier methods, use their natural cycle methods, or use their combined pills. But we often will not put in them an IUD. We wouldn't do that.
Okay, so Dr. Amadio, I'm coming back to you. So the question is there anything a woman can do to prevent getting fibroids?
$1 million question. So no, we know that there's nothing really that we can do in terms of food to prevent fibroids or just, but we do know that fibroids are fed by hormones, estrogen in particular. And so if you maintain an ideal body weight, that can possibly help make choices in terms of limiting your fat intake, that could possibly help. But otherwise, nothing in particular targeted towards fibroids to prevent a woman from getting fibroids.
Dr. Amadio, I have a follow-up question for that. So let's say your grandma had fibroid and she had to have it surgically removed. Your mom did, and you're now 32 and you do as well. What would you advise? Would you say to your child to consider doing something when they are of a reproductive age? Because I was having a conversation and someone was telling me that so she comes from a family of where almost everyone has experienced this, and because of that, once she got to the reproductive age, she just had her uterus removed because she didn't even want to have to experience that. So what do you say?
I think having the information is good. So we do know that fibroids do run in families. So having the information that maybe your grandparent had it, your mom had it is good. But I'm not sure that the approach should necessarily be surgery for everyone, because you may not have the same size of fibroids that your mom had. You may not have experienced the same symptoms that your family member experienced. So it really depends on what your own particular problem is with those fibroids or that fibroid. So it shouldn't be like a one size fits all. It has to be tailored to the particular individual in order to determine what to do. But I don't think taking out your womb at a certain age just to not go through the fibroid experience is necessarily the approach that I would recommend.
And if I may add, I will second that and say we should probably avoid permanent solutions for sometimes temporary problems. And one thing I always also like to remind patients is that medical practice has changed considerably over the years. And so maybe the time that your grandmother had fibroids, there were few alternatives to treating those apart from a hysterectomy. And so it's really important if we're having those symptoms and diagnosis of fibroids, you need somebody who has experience treating fibroids to have a good discussion. I do hope, though, that the questionnaire is not confusing fibroids with some other conditions for which women may choose to have, say, their ovaries removed and so on, who may be at high risk for cancerous conditions of the ovary, and in some cases even breast cancer conditions. Very different. By and large, fibroids are benign. They can cause a lot of complications and are annoying, but except for rare conditions, they are often not associated with cancer, and therefore have a wide panel ranging from doing nothing to medical to minimally invasive, with surgery usually as the last resort.
Thank you, Prof. So we have this question from Jackson, and he says, is there any other way of removing fibroids outside surgery? I know you discussed it earlier, but could someone quickly please Take your doing. Thank you.
Yeah, I think they didn't hear you too well. Um, but the question that's on the screen, I think it's been answered. But maybe Dr. Ntumi, can you just address that? Um, is there any other way to remove fibroids outside surgery? I think.
Okay, so I think that Prof. Tuli mentioned the alternative ways earlier. That is, surgery is not the only way of dealing with fibroids. I mean, the emphasis there is removed, but then there are other ways of treating the condition, from medical to non-invasive methods. And so, based on assessment that is done and a symptom that the patient came with, we may decide to manage the condition medically. Sometimes even just watching, just observing the patient and following up may be an option. But then if we must treat, we may have medical options available to us, from injection to oral medication that will take out the symptoms, to interventions such as uterine artery embolization that Prof mentioned, where you block the uterine artery that supply the fibroid node masses, where you may even have some form of I mean, MRI directed high frequency ultrasound scan energy to melt or to shrink the fibroids in a way, to medication that can actually induce a false menopause state to shrink the fibroid, but that's temporary. So there are ways to handle the fibroids without necessarily going for surgery. But most of those options are not permanent solutions, but they may be able to handle the problem up to a point.
Thank you. Dr. Amadio, are you happy to take the question on the screen?
What are some of the signs that depict fibroid shrinkage after menopause? So it still goes down to the symptoms you're experiencing. So if you were experiencing bleeding, usually during menopause, your bleeding stops. So that's an advantage of menopause. The other thing could be the size, the what we call the girth, the width of your belly, your abdomen. So that can start to go down. And then sometimes the symptoms you were experiencing before may be milder. So if you were experiencing a lot of pelvic pressure, a lot of pain, it may not be as much pressure that you're experiencing. So those are some of the signs that tell us that the fibroid may be shrinking. And of course, maybe doing an ultrasound to confirm the size and compare the size of the fibroid now to the size of the fibroid before menopause can also confirm that the fibroid is shrinking.
Awesome, thank you. I think Paul Mante is just talking about what the question I asked earlier on. So thanks, Paul, for your input. Okay, I've got a question for you, Dr. Ntumi. So generally, people say that you should be having your menstrual cycle for maybe 5 to 7 days. And there is this talk about bad blood. So let's say if you have a 3-day cycle, then for the remaining days, that turns into bad blood, and that has the potential of causing fibroid or turning into fibroid. Is that true, please?
Absolutely not. I mean, Dr. Amajo talked about what, and Prof talked about what possibly could cause fibroids. We never heard anything of blood clots transforming into fibroid nodules. And so that's certainly not the case. I mean, it's a myth. I know that, yes, there are a couple of some practitioners who would tell our patients that fibroids are the end result of blood clots that are formed and solidified into masses. And the same way, if they give them medication, they can be able to melt the fibroid. And they actually tell them that when it's melting, you'll be bleeding heavy clots, so that's the fibroid melting. So that is just a myth. And some people are use that to sell their medication and they make profit. I mean, when indeed there's no link. I mean, there's no way a blood clot can cause fibroid. And so people are being told that a woman must have their menses for 7 days. It's not a case. I mean, just as people don't have the same size, we are not the same sizes, we are not the same heights. The same way, number of days women bleed that men's differ from people to people. We all don't have to have the menses for 7 days. And so if you're worried about your menses, it's best to approach your doctor, your gynecologist, to assess and see whether it's a problem or not. But certainly, there's no way blood that is meant to come out that did not come out would convert or turn into uterine fibroid. That is just a myth. It never happens.
Okay, so as we come to an end, there's a question now on the screen that says, what's the difference between fibroids and polyps? So maybe that can be answered, Prof. Tuli. Especially in the developing world, so in, a lot of African countries, you go and you board a bus, like a commercial bus, and you find people selling herbal medicines, to the passengers. And a lot of times you hear people talking about, herbal medicines for causing fibroids to melt. It's kind of similar to what Dr. Ntumi was addressing. I mean, are there any real kind of medications, whether herbal or otherwise, that can cause fibroids to melt?
So I'll take that and then the question on the screen. So let me start off by being respectful to our traditional herbal medicine. I think there is some value to at least some of them. But I also always like to remind us that even modern medicine are medicines that we have been discovered through looking at molecules and chemicals from some of these herbs and so on. And so I tend to see modern medicine as maybe the more advanced or purified forms of some of the herbal things that people may sell. So I'm not, just because I'm a Western doctor, I don't want to say all herbal medication is bad and so on. But I will say that, especially as far as this question about fibroids are concerned, that there is no plausible herbal medication that is known to melt fibroids. The other thing is that, even in our traditional medicine, the people who may be true effective herbalists are usually not in the buses selling medication. They may be, renowned people in the village who may be able to provide some of that medicine. And there are sometimes also concerns about safety. So there have been times when people have taken some of those herbs and it's affected their liver and maybe lead to liver failure and so on. So I would generally say we should be cautious about, using some of those herbal medicines, especially those that make these fantastical claims, including melting things and so on. Now, moving to the question about the difference between fibroids and polyps. So a polyp is simply what we describe as a tissue that is hanging usually inside a cavity. In the case of the uterus or uterine polyps, it is tissue that is hanging inside the uterine cavity. Most of the time, that tissue is made out of the inner lining of the uterus that has just overgrown and hangs over on itself, and that is a polyp. Occasionally, a fibroid may also be within the uterine cavity, have a narrow stalk, have a narrow pedicle, and also appear like a polyp. So polyp is a very general term for structures on a narrow pedicle or stem hanging in the uterine cavity. As I said, most of them being just inner lining of the uterus that has folded upon itself, but sometimes that could be a polyploid fibroid, meaning a fibroid that is hanging on a narrow stalk within the uterine cavity. So a fibroid can appear as a polyp, but not all polyps are fibroids.
Thank you very much to our lovely panel and to you viewers for staying with us. So we are just wrapping it up now. I'm going to come round and then ask each one of you to give us a message to take home, please. Just something that you are really passionate about, assuming the viewer didn't hear anything throughout this an hour and almost half or 2 hours. What would you like them to take home? What would you like them to hear, Dr. Amadio?
As far as fibroids, I think for the viewers back home, there's a lot of myths. And I think one of the things that I encountered, or whether the situations, was a lady who said she'd been pregnant for almost a year and it was obviously a fibroid. So one of the things I encourage our viewers to do is to seek medical treatment and to seek medical treatment on time so that less invasive, options can be explored between you and your doctor, and not waiting till the fibroids are really grown to seek treatment, and not to be afraid to ask your doctor for what your options are. So that's what I would want our viewers to know.
Thank you. And Dr. Ntumi?
Yes, so to sum up, I would want my viewers to know that, fibroids are very common, and the take home here is this. If you have infertility and have fibroids, it doesn't necessarily mean that the fibroids are the cause of the infertility. So it's better to seek help where you'll be evaluated and the cause of the infertility will be identified. And if it is fibroid, you'll be helped so you can achieve pregnancy. That's my take home.
Thank you very much. And Prof. Tuli?
So I will continue from what Dr. Ntumi said and give a word of hope, which is that, again, fibroids are very common. And so it is common for pregnant women to have fibroids. And so just because you have fibroids does not mean you are going to have infertility or pregnancy complications. And just because you have fibroids and you are pregnant does not mean you are going to suffer a miscarriage or one of those complications. The vast majority of patients with fibroids who are pregnant will do just fine.
Awesome, thank you. Prof. Lai, so we usually do this. Why is it really important that we discuss this topic today? So we usually do it at the start, but today we are doing it at the end.
Yeah, so, as has been said, fibroids are very, very common. And, Dr. Amadio kind of did a good job explaining that, it's common across the board in all societies, so it's one of the common things that gynecologists do. And Dr. Ntumi kind of mentioned, that it's about maybe 50% of the open, surgeries that they do is to deal with fibroids. So it's very common, and that's why it's important for us to discuss this topic. And as I can see from a lot of the comments coming up, people have learned a lot, about this. And so I think this has been a good topic to discuss. And most importantly, coming up to next week, usually we don't do back to back, but because of how important this is, we're doing back to back. And so next week we are coming back actually to talk about infertility. And I think this is even going to be much more educative. And we want to make sure that, if you are married, come on board with your partner, with your spouse, because we're going to talk about not just the female, because infertility is a couple issue. And so we will talk about both the female and male causes, and talk about infertility from the standpoint of a couple, and make sure that we address every question you have, because a lot of times, especially in African communities, when a couple is dealing with infertility, most of the time they tend to blame the woman and put a lot of pressure on the woman. However, we are going to learn a lot next week about what infertility is, and what the different contributions from both men and women are. And so I think that you don't want to miss next week's session. Thank you.
Thank you very much. So, Paul Mante, I hope this answers your question. So we are here every Sunday, but we discuss more of the biblical topics on Sundays, and then once every 5 to 6 weeks, we the medicals come on board and we discuss these topics. However, like Prof. Lai said, just for this very special occasion, we are going to be discussing infertility next week. So I hope you invite a friend to invite a friend to invite another friend. And to my lovely panel, thank you so much, so much for joining us. Dr. Michael and to me, thank you, Dr. Majo. Thank you, Prof. Tuli, and thank you ever so much, Prof. Lai. We have come to the end of the show. I have a question here. I didn't see it, and I'm not sure. We have a few more minutes. I'm not sure if somebody would be happy to take it before we go.
I think, okay, Prof. Tuli, can you just quickly just address it?
So the question is, if the fibroid is as large as 36-week pregnancy, then it is likely you can carry a pregnancy to term. How true is that? I think there's a lot of truth in that. So if you think about it, 36 weeks, it means that the uterus is almost at the level of just below the chest. That is a very large uterus. And, with that size of a fibroid, the uterine cavity is likely to be very distorted. If there is even a pregnancy, the pregnancy will be squished. And so I would say that is a very large uterus. You never say never in medicine, but a patient with a 36-week size uterus, I would say would be very unlikely to be able to carry a pregnancy to term.
Oh, thank you so much, Prof. Tuli, for doing that last minute one. And the thank yous coming in is just amazing. So many questions has been answered. And viewers, please, if you have any further questions, please come next week. Like Prof. Lai said, we are going to be talking about infertility, and we want to take it from the couple viewpoint. So it's not a male problem or a female problem, but both of you should come together and come and learn something new. Thank you so much. So we've come to the end of today's broadcast, and see you all next week, Sunday, 8 p.m. British summer time. Thank you. And my dear panelists, if you could just stay online, we'll have a quick chat afterwards. Thank you.